Good evening, all. I am Dr. Jayakumar Menon, a laryngologist by profession. I work in hospitals in Trivandrum and Cochin. I work in PRS Hospital, Thiruvananthapuram, and Aster Medicity, Kochi, as laryngologist. Also, I am the head of the Department of Swallowing Division in the Head and Neck Surgery Department in Amartha Institute of Medical Science, Kochi. I am also a visiting consultant in laryngology to the Sri Chitra Tirunal Institute of Medical Science in Trivandrum. Today, we are going to talk about the chronic cough. As an ENT surgeon, I get a lot of patients with complaints of chronic cough, which is already have been consulted or who have already been seen by the pulmonologist or the general physician, and the lower respiratory tract is normal. So you can call it probably non-pulmonary chronic cough. It is actually a very common problem. Many patients have that, and it's a global problem. Many, even national, international, there are a lot of patients with this problem. You might have seen during the last American election, Miss Hillary Clinton was having that lot of cough during her campaign program, and our own Delhi Chief Minister Kejriwal also, you might have seen, had this problem sometime in the past. So it's a very common condition, but many times a little bit troublesome to treat. So we will go into the details of the chronic cough and how we can manage it best. There have been a lot of work going on regarding the chronic cough. The two pioneers I will consider are Dr. Jamie Kaufman and of course Peter Belawski. They have contributed immensely to the understanding of pathophysiology of chronic cough as well as the management of it. So, how we should approach a non-pulmonary chronic cough patient? That is the question here. Just like in any other medical condition, we should start with a detailed history taking. And probably this is even more important in chronic cough, because vast majority of the conditions, the chronic cough cases, can be properly diagnosed only with a very detailed history. So spend a lot of time in history. We will go into the details of history taking a little more elaborately in the coming slides. But the general pattern will be ask about the onset of the cough, any specific aggravating factors, past history, especially the history of childhood asthma, substance abuse, use of tobacco, alcohol. Medication is very important. We all know that drugs like enalapril can actually cause chronic cough. So take a very detailed history of medication, and of course medicines which can cause reflux, that can also indirectly cause cough. And ask about surgical history. Did the patient have any surgery on the neck which could have probably adversely affected the larynx and its nerves? So history taking is very important. And then go with a standard clinical examination. Sometimes it can be very trivial. We all know that sometimes earwax can produce chronic cough. So don't forget to look into the ear. I myself had a very embarrassing experience quite a few years back. one of my clients who was fairly a very famous singer had this cough. He was telling that he was getting cough very, very frequently. I just went on. I saw the wax, but I thought it was a little bit soft wax, so I didn't think much about it. I just treated with him anti-reflux and all, but there was no improvement. And then he came and told me that, doctor, I also got a problem of having, I'm not able to hear my own voice when I'm singing. So there is something. So I told, okay, there is some wax, I will clean it. So I cleaned it and then send the patient back. Then surprisingly, he called me next day saying that, doctor, is very good. Now I can hear my voice back, and surprisingly, the cough also has disappeared. And then only I knew that even soft wax sometimes can irritate. So don't think lightly of wax. If in a chronic cough patient, if you see wax, you clean it. That's very important. Postnasal drip, it is very easy to find out. So do a general ENT examination, look at the oral cavity, oropharynx, nasal cavity, everything you should see. And if there is a postnasal drip, that may be the cause. So look for postnasal drip too. And do a thorough examination of the neck. Especially look for retrosternal goiter. Sometimes apparently there won't be any neck swelling, but the patient may have a retrosternal goiter, and it may be compressing the trachea and causing cough. So always look at the superior mediastinal region very, very carefully. Take some time and palpate for the thyroid swelling. This is very important. And auscultation in laryngology is important. Auscultate the neck, auscultate the chest. This is important. In the neck, listen for any stridor, because there may be a laryngeal or tracheal lesion, very rarely producing cough. And chest, look for wheeze, because it could be a cough variant asthma. It's not a rare entity. And also in the past history, you should ask about the childhood asthma. So all these things are important. So auscultate over the neck and auscultate over the chest. Don't miss that point. But the vast majority of the non-pulmonary chronic cough belongs to two groups. One is known as the silent airway reflux, or what we usually call it as the LPRD, or the laryngopharyngeal reflux disorder. We actually sometimes even overdiagnose. Laryngologists have got a tendency to find LPRD everywhere, but that is an entity, may be overdiagnosed, but it can cause cough, no doubt about that. But the second, not that well-known entity, but equally important is the neurogenic cough. It's also known as PVVN, or post-viral vagal neuropathy. After an infection, upper respiratory infection, the airway can be irritable, and this can go on for a long time, weeks, sometimes even months. And I have even seen patients who had chronic cough for years. So that's not rare. Once that is irritated, the airway is irritated, they keep on coughing. So 40% of the non-pulmonary cough may be even neurogenic cough. So be on the lookout for it. Unless you are aware of it, and unless you look for the signs and the symptoms, you won't diagnose it. So it's very important to be aware about this particular condition known as the neurogenic cough. So these are the two major conditions. All other conditions I told about, the NLF, the drug-induced postnasal drip, wax, thyroid, all these things, chronic cough variant asthma. But we are going to the details of these two major conditions. How to diagnose? We will see. The interesting thing is that many a time you can actually differentiate these two conditions by a proper history. That is why I told in the beginning, history taking is so important. So take lot of time in history and identify the points. A cough due to a laryngopharyngeal reflux disorder, there are 5 points in history. Remember them. 1. many of them wakes up from the sleep with cough. That's very typical. Their cough usually is more in the sleep or more, and they can actually wake up from their sleep can be disturbed with bouts of cough. Second is that some of them may even have severe transient choking episode. They may even get scared. They may think that the death is impending because for a few seconds they might even get breath. So this is known as the ILS or irritable laryngeal syndrome. Again, we are very familiar with condition, but patient may not be. So first time that gets, patient will be really scared. Not only the patient, but the bystanders, because they are helpless. The patient is not getting any breath at all, and there is this frightening inspiratory stridor like that. They are not getting breath. But we know that this is, even though it looks frightening, it's actually a self-limiting condition. Once the oxygen saturation goes below a particular level, the reflex arc breaks and the larynx opens. Nothing will happen. Usually the typical history will be that patient woke up with severe breathing difficulty. They frantically ran to the nearest hospital, reached a casualty, they gave some medicine and then the condition improved. But actually it is not the medicine which controls, it's a self-limiting condition. But it can occur again and again. The third major point in the LPRD cough is that cough while lying down. Many patients will say that my cough starts when I go to sleep after in the evening, in the night. So this is because the gravity which protects to a great extent the reflex from stomach to the larynx or the pharynx is actually gone once the patient lies down, because both the throat and the stomach are at the same horizontal level and reflex can easily occur. Fourth point will be, patient will say that he or she has got cough after food intake. That again typical, because the irritating food will cause acidity, acid reflux will happen, and it will cause cough. And fifth point is not very common. Cough when or sometimes after stooping, especially in patient who has got hiatus hernia. When they do that, there will be lot of amount of reflux go onto the pharynx, patient will cough. So that is not rare. On the contrary, the 5 points for post-viral vagal neuropathy is different. Patient will have cough only throughout the day. Once they sleep, there is no cough. This practically rules out. If patients say that I don't have cough once I sleep, it practically rules out LPRD. It doesn't say that it is laryngopharyngeal reflux. It is almost typical of neurogenic cough or PVVM. Second is that these patients are highly sensitive to temperature changes. So they will tell that now once the fan is switched on, once the AC is on, I start coughing. This also should arouse the suspicion of neurogenic cough. Third is laughing. When they talk or laugh, it produces a lot of cough. And another typical history is that fumes cause cough, especially perfumes, fuel, the smell from the kitchen. They all can be highly irritating the patient with the neurogenic cough. So that history also should arouse the suspicion of that you are actually dealing with a neurogenic cough patient. Speaking, singing can cause coughing. That can be a very big nuisance to many patients, especially if they are singers, because when the voice is producing, they can have cough. One thing you should remember is that it's not a watertight compartmentalization. Some patients will have actually both neurogenic cough as well as reflex cough. And even when there is no obvious reflex, chronic cough itself is sufficient to cause reflux because of the increased intra-abdominal pressure. The acid will go up and it will cause irritation of the larynx and it will further cough. That is a vicious cycle. So be careful about that. When you make the diagnosis, make sure that you have detail all these things. That was by the history. Now, how you differentiate by the laryngoscopy? To do a flexible laryngoscopy or rigid laryngoscopy doesn't matter. We can do that, and I think most of you are familiar with the laryngoscopy finding or the reflex finding in LPRD. The classical will be the interarytenoid pachydermia. You can see that between the arytenoid there is a thick web-like thing. You can also see the pseudosulcus. It is different from the true sulcus in the fact that it runs the whole length of the vocal cord. True sulcus will never go posterior to the vocal process. So, pseudosulcus, interarytenoid pachydermia, they are the two major signs. Posterior laryngitis means the arytenoid will be quite red, especially the medial and the anterior part, and the ventricle will be very shallow. That is because of the reflex, the mucosa get edematous and the ventricle will become shallow. So, they all are well-known signs of reflex. You can have thick mucus, and vocal process granuloma is not a completely reliable sign of LPRD, but it can. Usually, vocal process granuloma is due to the technical fault of speaking. If they speak in a very low-pitched bass voice, but in the presence of LPRD, vocal process granuloma can occur. So, vocal process granuloma suggests that there is a possibility that patient has got reflux. So, these are the endoscopic findings. Now, what will be the endoscopic finding of PVVN or post-viral vagal neuropathy? Usually, it will be almost normal larynx. But if you look very, very carefully, many of them may have actually what to go back? Yeah, no. Sorry about it. Yeah, it's not playing. Anyway, that video is not playing. I don't know exactly what is the reason. Anyway, so what is usually happening is that there will be usually the vocal cord will be normal looking. Sometimes there may be a subtle vocal cord paresis may be there, that you can only find out by looking at the arytenoid. On the paralyzed side, the arytenoid might cross over the midline. Next is that some patient can develop severe ulcerative laryngitis. How means the vocal cord will be. 1 second. Can I get that connection regarding the how does it play? It's not playing that video. No, it's going to the. No, it's no. It's the next slide now. It's all going. How to play the video is the question. Then it goes front. See that it actually go back. It's not playing. That video is not playing. No, that's not a video. That's not a video. That's not a video. Good. Okay. So in idiopathic, the neurogenic cough, if we can sort out a little later, I can show that. So another finding, one subset will be the vocal cords will have lot of small ulcerations. That is because of the impact of the vocal cords hitting against each other. So secondary to that ulcerative lesions, patient can have actually some amount of hoarseness too. So if you see multiple small whitish ulceration on the medial margin of the vocal cord, in a non-smoker patient, that may be just neurogenic cough. Sometimes it can even imitate a malignancy. But that history should actually help you to differentiate it. Illa. Video won't. Okay, video won't be playing. Okay, right. Okay. Now, other investigation is that now, you are all familiar with transnasal esophagoscopy, I suppose. One of the standard indications for transnasal esophagoscopy would be a chronic cough. We need to do that. You can see that the transnasal esophagoscopy is being done. It's done an outpatient procedure, not much discomfort for the patient. It is passed through the nasal cavity, go down the cricopharynx, go to the lower end of the esophagus, see the stomach, and then come back. So you can rule out a lower esophageal pathology so that there is no major problem like hiatus hernia, Barrett esophagus, lax esophageal sphincter. All these things need to be looked at in case of chronic cough. You can get different kind of findings. This is a normal thing. Sometimes you can even accidentally pick up tumors, esophageal erosions, Barrett esophagus. You can get hiatus hernia, and also this is a video, so won't be able to search. You can see that the acid coming up into the cricopharynx. You can see very clearly. So all these things can be picked up by the transnasal esophagoscope, which will actually give a clue regarding the reflex. Now, if the facility for esophageal pH metry is there, a 24-hour esophageal pH metry should be done. And if the patient shows acidic pH above the upper esophageal sphincter, then that's a very big evidence of laryngopharyngeal reflux disorder. That means hydrochloric acid is coming up. And in presence of laryngeal finding of reflux, that actually clinches the diagnosis. But you can also have non-acidic pH above the UES. And in presence, so if there are findings of laryngeal findings of reflux, and you get a non-acidic pH above the upper esophageal sphincter, then you should make a diagnosis of pepsin-induced reflux. Pepsin is probably more damaging than acid, and it can create lot of symptoms. And a minority of patients, of reflux patients, pepsin is the culprit, where treating with the pantoprazole proton pump inhibitor might not get a desired result. Again, not every center will be having, but esophageal manometry, esophageal and pharyngeal manometry can be useful. So you can see the pressure at the LES, lower esophageal sphincter, and the upper esophageal sphincter, so that the difference at the pressure level can be easily diagnosed, and then so that you can actually make a diagnosis of reflux disorder. Radiological investigations are important. Most of these patients will actually be coming to you after already seen by a pulmonologist or a general physician. But if they have, and I'm sure that they would have done all the tests like pulmonary function test and X-ray test. But if they are coming to you directly, never omit doing an X-ray test. This is one of my own patients. Her patients, her symptoms were fairly innocuous. She had cough during night after food. So I was about to dismiss her as a case of reflex-induced cough, laryngopharyngeal reflux disorder. But then auscultation was also not very convincing. But I thought I'll take an X-ray, and it turned out to be a huge lymphoma. So tuberculosis, lymphoma, they all need to be diagnosed. Most of the time, if the pulmonologist has seen, that is fine. But if they're coming to you for the first time, always do an X-ray test. And if you're in doubt, always get the opinion from your pulmonology colleague. Sometimes further radiological investigations may be required, like barium solid. Pharyngeal pouch is actually a cause of chronic cough because that obvious reason. There will be a lot of collection of the food, and later they actually evacuate, and part may go into the larynx, and patient can have cough. Tracheoesophageal fistula can be another cause. So these things can happen. So in selected cases, you may have to do not only a plain X-ray but also do the fluoroscopy, and if needed, barium swallow, and if needed, the fluoroscopy evaluation. And CT scans are sometimes required. This is again one of the case presented to me. She had more cough than breathing difficulty, but actually it was a leiomyoma of the trachea. So that can happen. So in doubtful cases, go for all radiological investigation. This is not my case, but a reported case. There was a pin in the foreign body in the trachea, metallic foreign body. So all these things can occasionally happen. So don't leave anything to chance, because these patients, even though symptoms may be a little bit trivial, you have to be careful if it is especially persistent, because they are unlikely to come to you unless it is persistent. All these patients have been suffering a lot. They have been having cough for long time. So do a thorough investigation, and it is very rarely that you will actually miss the diagnosis. Take history, do a thorough clinical examination, and do whatever investigation which you deem is necessary. You can do the laboratory investigation like the blood count, ESR, and all the tuberculosis test. All these things should be done. Don't leave anything to chance. And sometimes you need a psychological consultation, because there's a third variety called psychogenic cough. Sometimes it is very difficult to differentiate from a neurogenic cough. Like in neurogenic cough, psychogenic cough also will be only during daytime. Now, once the patient sleeps, it will not be there. So how to differentiate? Sometimes it is very difficult, but you can. It is more in children, sometimes in attention-seeking children, as well as young ladies, it can happen. And the two clinching points should be, unlike neurogenic cough, even neurogenic cough also has got a psychosomatic element, I agree, but psychogenic cough will be worse when observed. So when the doctor is coming, patient may cough more. When the parents are there, they may cough more. So that should actually alert you to the possibility that you are actually treating a case of psychogenic cough. And another important point is that cough is not as forceful as in neurogenic cough. In neurogenic cough, the cough is really violent. It's very forceful. It's very disconcerting. Psychogenic cough, they will not be coughing like that, because they are not hurting themselves. Neurogenic cough, they are not acting, but they are not malingering. So psychogenic cough, the cough will not be as forceful. So these are the 2 points which will probably help in you differentiating a psychological from a neurogenic cough. But sometimes it can be really difficult. Now, once you have reached a diagnosis, how to manage? LPRD, I think we all know the diagnosis, the management. Hydrochloric acid is best treated by the proton pump inhibitors. I don't think there is any superiority of one PPI over another. Select according to your convenience. I generally give pantoprazole 40 mg twice daily. So it is double dose, double duration. But if it is pepsin, then this is not going to work. If you have got a facility for pH metry, you can differentiate. If you don't have, you have to treat empirically. If there is no improvement with the PPI and there are reflex findings for, you should think that it is pepsin. So only medicine available as of now is the alginate, which is under the trade name of Gaviscon, as well as reflex liquid can be given 2 teaspoons 3 times daily should be good enough. So they are the medication, and you may have to give as long as 6 weeks. But one important point in the management of reflux cough is that you have to suppress the cough, because each time patient is coughing, there is an increased intra-abdominal pressure, and that itself will cause reflux and further cough. So you have to aggressively treat cough. So give something like a cough suppressant. Generally, the preferred thing I give is a Benadryl cough suppressant. That is quite good enough. So any thing, is like a lot of other things are there. Usually that should be good enough. That generally combine this dextromethorphan. All these things are good enough. But you select according to your convenience and your experience. Prokinetic agents may be good in refractory cases. But one thing you should highlight to the patient is that it's not the medicine. Many patients believe that, okay, doctor will prescribe medicine, my reflux will go away. You should take a lot of effort to convince them that it is not like it. The proton pump inhibitors and the alginate are only for the control of the symptoms. The real treatment is by the lifestyle modification, especially the diet modification. They should find out which all foodstuffs produce problem for them and avoid them. That's the most important thing. Cheese, chocolate, spicy food, extremely sweet things, all these things they should understand. It may vary from individual to individual. So they have to find out what is wrong with me, or what food is not ideal for me. Cut it off. That is the clue. Otherwise, they are not going to get cured. And of course, this is again well known. Sleeping immediately after food is not a good idea, because it takes really 1.5 hours or more for the food to move out of stomach into the small intestine. As long as the food is in the in the stomach, once the gravity is eradicated, the reflux will happen onto the larynx and patient will have cough. So never allow the patient to sleep immediately after food. Minimum 1.5 hours, ideally 2 hours. So the best thing will be take an early dinner and little bit delayed going to bed. If they are very particular to sleep immediately after food, they should be instructed to sleep on a couch, so that the throat will be at a much higher level than the stomach, and only after 2 hours they should go to bed lying flat. This is applicable to this afternoon nap also, because after lunch you cannot have 2 hours waiting and then going to bed. That is not possible. So many people will sleep immediately. So they should be instructed, if they are having problem with the chronic cough, or if they are having problem with reflux, they should be instructed to sleep in a proper position. And never use very tight clothes and tight belts. This is trouble. And again, you might see in the advertisement, the quick ways of reducing the abdomen and all. They all actually can create a lot of problem with the reflux, because they are actually compressing the abdomen, increasing the intra-abdominal pressure, and lot of reflux can happen. So that shouldn't be there. It should be loose, and relatively loose fitting dress. Now, management of neurogenic cough. There has been some change. Previously, I think baclofen and gabapentin were more commonly used, but now the drug of choice is actually amitriptyline, and use it in a small dose. 10 milligram amitriptyline is the standard beginning dose. Tell the patient that they will have some sedation in the beginning, but as the sedation goes off, sometimes the cough may come back. Usually it responds very well. So start with 10 milligram, review in 1 week time. If patient is comfortable, the cough has reduced, continue the same dose. But if after 2-3 days the cough is coming back, increase the dose. You can go up to 50 milligram, maybe in 2 divided dose. Many times if you gradually increase, there won't be much sedation. One reserve line of drug, but very efficient drug in controlling chronic cough, neurogenic cough, is tramadol. Again, you can use 100 milligram twice daily, and maybe even slightly more, and then actually once the cough is controlled, you can reduce the dose. So these are the major medicines. So Currently, I think the line of selection will be amitriptyline first, tramadol second, and baclofen and gabapentin as the third and fourth drug. And generally, most of the patient will actually improve with this medication. Amitriptyline and tramadol, and many patients like prolonged treatment. That's the important thing. Once the patient's symptom is controlled in 2 weeks, don't immediately withdraw the drug. Patient will invariably go. So gradually wean off. A rough calculation will be how long patient had cough, that much you should give. So that means if patient is complaining of cough for the last 3 months, give it for 3 months and then gradually wean off. This was a video, but of course the video is not playing. You can see this patient had massive neurogenic cough. He even lost his job, but with combined treatment of just with amitriptyline he improved, but it was not controlled. Then the tramadol was added, then gradually it was withdrawn. So you can use the medicine and control it. And now the latest addition to the armamentarium of treating chronic cough is botulinum toxin. So botulinum toxin is finding newer and newer indications. Refractory cases you can inject. I myself have injected now 3 cases. They all do very well. But I will leave it as a reserve line of drug. What you are doing is you are actually modifying the cough response. So you inject botulinum toxin 2.5 units into each thyroarachnoid muscle, either under laryngeal EMG control or under flexible endoscopic visualization. Both these are fairly effective. So inject them, control it. You tell the patient that your voice will be a little bit weak, but usually the cough will control. So this is the indication when the cough is so refractory, you cannot even control with tramadol and amitriptyline combination. Now, sometimes you come across a condition where patient is continuously coughing in front of you. He cannot sit quietly. That's a very distressing, difficult condition. So how you can control acute exacerbation? So again depend upon diagnose. Is it an LPRD? Is it a PVVN? If the LPRD, the reflex arc is superior laryngeal nerve, nucleus ambiguous, recurrent laryngeal nerve. So block the superior laryngeal nerve. We can block it by injecting xylocaine or bupivacaine into the thyrohyoid space, lateral part of the thyrohyoid space bilaterally, so that the superior laryngeal nerve is blocked. But if it is a PVVN, post-viral vagal neuropathy, then the reflex arc is recurrent laryngeal nerve, nucleus ambiguous, recurrent laryngeal nerve. Recurrent laryngeal nerve is a sensory as well as motor. So here you can block it by giving a classical transtracheal. Puncture the cricothyroid space, aspirate, make sure that you are in the trachea, and instill few drops of topical xylocaine. Now, before I conclude, there are few things about the new specialty of cough therapy. This is a emerging specialty of speech and language pathology. Few speech and language pathologists are now getting trained in cough therapy. This was necessitated because of the problem, the magnitude of the problem of chronic cough. Lot of patients have this problem. So like in swallowing therapy, here also there is direct cough therapy and indirect cough therapy. So in a nutshell, what is direct cough therapy? There are a few things. One is known as the cough swallowing. If patient is continuously coughing, one of the problem may be that, that supraglottis is more sensitive than the subglottis. So if there is mucus over the vocal cord, this can be easily removed by asking the patient to cough and immediately swallow. So it will be something like swallow immediately. So multiple swallow will cause the larynx to move up and anteriorly, causing the mucus to dislodge. Then next is the cough breathing. That is known as the paradoxical vocal cord movement. You intentionally create a paradoxical vocal fold movement. What will happen? The mucus sitting over the top of the vocal cord will get sucked into the subglottis, which is less irritating. So it will be something like like that. So cough breathing can actually create some improvement. And there are a lot of studies saying that nasal breathing is better than oral breathing in cough. So if you are breathing highly humidified, nasal air is better than oral breathing. So instruct them to breathe only through the nasal cavity. Don't keep the mouth open. Breathe through the nasality. And again, studies have proven that lower the respiratory rate, lesser the chance of cough. So ask them to cut down slow, gentle, quiet breathing through the nose. So it should be something like that. So cut down the respiratory rate and breathe through the nose. That might help you. Indirect cough therapy is not directly at the cough, but something away from it. So one of the common thing is distraction therapy. I told in the beginning that neurogenic cough, even though there is a definite structural problem, it is a psychosomatic disorder. So that part you can treat. Many patients themselves will say that when they are concentrating on some job, their cough is less. So distraction therapy is giving them some job, some activity which require intense concentration. So that might help. And teaching them vocal hygiene, take hydration, humidified air, good vocal habit, good food habits, all these things can actually help. And some patients obviously will require psychological counseling too. So this is in a nutshell about the current concept of chronic cough. So when you get a chronic cough, it is very easy to lose the high definition. Now we can actually go all around and you may actually miss the point. So the clue is locating or identifying what exactly is the cause. Once you identify the cause and you are zeroed down to the real diagnosis, management is not very difficult. Vast majority will be very, very thankful to you. I have got lots of patients, even patient who had, recently I have a patient who have been having cough for nearly 14 years on and off, a 71-year-old lady. With tramadol, with the amitriptyline, there was not much improvement. When I added the tramadol, it started improving, and 2 months time the cough almost stopped. So it's actually a very distressing condition, but as ENT surgeons and laryngologists, we can certainly help most of them. Occasionally you may come across a patient which is very, very, very resistant to all this treatment. But with the advent of Botox too, I think we can control vast majority. The real problem I face is that it is a psychogenic cough. They are very difficult because it's not, it's really not your domain. So once you are sure that that is a psychological cough, certainly get the support of your psychology colleagues. You should be able to manage them and relieve them of this very distressing symptom. Thank you very much for listening to the talk. I'll be happy to clear any doubts as far as I know. Thank you.